So pneumothorax is the collapse of the lung due to the air accumulating in the pleural space. This space between the lung and the chest is known as the pleural space. It has serous fluid that helps both opposite walls glide during inhalation and exhalation. This then also creates a negative pressure which acts like a suction to keep the lungs inflated. So there are two ways air can get into the pleural space. Either there can be a spread of air from the lungs into the cavity, or there can be a movement of air from the outside into the cavity. So this would be closed pneumothorax, and this would be open pneumothorax. Sometimes a situation can occur when there is only a one-way movement of air, and that is known as tension pneumothorax. It is defined as a one-way path where air gets collected but never leaves. Basically, your pleural cavity gets inflated like a balloon, and that's not good. This is a medical emergency and is life-threatening. Any type of pneumothorax can lead to a tension pneumothorax, and it's basically where air does not escape from the pleural space. Let's take a look at its pathophysiology. The air in the space is negative. During inspiration, the pressure decreases, becoming even more negative. The pressure outside, as in the atmospheric pressure, is positive, and that's what you inhale. So when there's a damage to the chest wall, resulting in tension pneumothorax, air will enter the chest naturally. The inside pressure will then increase and become positive. The rest of the effects are based on this logic. Three major things will happen. First, the affected lung will collapse and the inflation of the pleural space will basically compress and push the remaining structures, which would be the trachea and the heart. So the trachea shifts to the contralateral side and the heart here will have a mediastinal shift. Along with the structurally disturbed heart, the superior and the inferior vena cava will also be disturbed. There will be a kinking of these vessels, all these ending up with a patient functioning with just one proper lung. So these activities can be easily translated into symptoms. So the affected vessels result in a decreased venous return and a low cardiac output. This will be translated as a person with low blood pressure. The tracheal shift would end up with the patient having a decreased lung function and will cause impaired respiration. The kinking of the vessels will also cause distended neck that can be seen on physical examination. Sometimes patient can also end up in obstructive shock. The biggest thing is that the affected lung has no air entry and it's not functioning, so there won't be any breath sounds. These are very indicative of a pneumothorax. So an easy mnemonic to remember for the symptoms of pneumothorax is through P thorax. P for pleuritic pain, T for tracheal deviation, H is for hyperresonance due to the lack of air movement in the affected lung, O for sudden onset, R for reduced breath sounds or dyspnea, and A for absent fremitus, and the x-rays will show collapse. So let's look at the findings of an x-ray. These findings are very straightforward, as you will see. Right here is the tracheal deviation, and the size of the lung on the affected side is also decreased. The heart is slightly shifted, and the expansion of the pleural space has caused a depression into the diaphragm. A tip-off on auscultation is known as the Hammond sign, a rasping, crunching sound heard synchronized with the heartbeat as the heart is beating against air-filled tissues. So how do we treat this? The key physiology here is that air is going one way and the cavity is expanding such that the air cannot escape. So the first immediate step is to essentially make a hole so that air can escape. So a wide bore needle insertion procedure is done. Right down the mid-clavicular line, on the second intercostal space, you insert a needle of size 14 to 16 to essentially allow the air to escape. You can actually hear the sound of the air escaping. So this is known as the wide bore injection procedure. So now that we've done this, now we have a patient who has air interaction from the lung to the cavity and air interaction from the outside to the cavity. This tension pneumothorax has now become a simple pneumothorax. So now the next thing we need to solve is positive pressure that's still in the pleural cavity. So to do this, we do what is called a chest tube or a suction mechanism. We basically drain the remaining pressure out. So on the fifth intercostal space, Right between the mid-axillary line, we insert a chest tube that acts as an underwater seal suction mechanism that kind of troubleshoots and sucks out the air using a water seal chamber. While this tube thoracectomy is happening, the initial wide-bore needle is still placed inside. Now we end up with a stable patient, but we still have to find out what the etiology is. And to do that, we can do an emergency thoracotomy. Maybe it was a bullet that caused a puncture, or we have to do a lobectomy, or maybe there's a collection of blood. Okay, so the next one we're going to look at is spontaneous pneumothorax. This usually occurs in a patient that already has a history of a lung disease. So let's say a patient with emphysema comes into the office. An emphysema person usually coughs a lot, right? So the key points here is that this is a spontaneous, as in a sudden onset, pneumothorax. So what happens is that the patient would have coughed so much and so vigorously that there would have been a rupture of the bleb, causing a sudden collapse of the lung. So this ruptured bulla causes the air to escape from the lung into the pleural cavity. The already weak air sacs and the ruptured bullas cause an intrinsic weakness of the lung parenchyma. So on a chest x-ray, a pneumothorax will typically demonstrate a visible visceral pleural edge, as seen here with these very thin, sharp white lines. There are no lung markings as seen peripheral to this line. Normally there aren't any vascular markings, but in this case you can see small vascularities with blood vessels thinning out. The mediastinum should not shift away from the pneumothorax unless there's a tension pneumothorax present. So spontaneous pneumothorax can be treated by looking at it in two ways: a patient with cyanosis and a patient without cyanosis. Now, if the patient has cyanosis, this type of pneumothorax has to be dealt with a chest tube. So you insert a chest tube at the fifth intercostal space, mid-axillary line, and you have a underwater seal suction bag attached to it. You'll usually get air and blood along with it. If there's no cyanosis, then you can directly go into a needle aspiration, not a lumbar puncture or a wide bore, but it's a needle aspiration with a 14 to 16 size cannula. So a quick recap: tension pneumothorax is an emergency situation. It has to be dealt with promptly. The chest x-rays would show a tracheal deviation, and a key sign on auscultation is the Hammond sign. To treat it, you do a wide-bore needle to make it a simple pneumothorax, and then you insert a chest tube, and then find out the etiology of the tension pneumothorax. For spontaneous, you conduct a lung puncture and check if the patient has cyanosis or not cyanosis. On chest x-ray, you would see vasculatures plus a shrunken lung. Remember, spontaneous pneumothorax is usually seen in patients who already have an existing lung disease. They are usually smokers, people with Marfan syndrome or predisposed to it. And that ends the discussion on pneumothorax. Thank you for watching.